Sharing. Okay, just a second. Are you guys audible now? Sorry, am I audible to you guys now? No response. Okay, so the first question is, which of the following structures is not attached to the modulus? Okay, so we all know a modulus. What is a modulus? Okay, so modulus is a ring-like circular muscular structure around your lips, right? So which of these muscles is not attached to the modulus? You have quadratus labii inferioris, depressor anguli oris, zygomaticus major, or the zygomaticus minor. The answer for this is basically the zygomaticus minor. So how do you remember which all is connected to the modulus? Which is not there to the modulus? So you remember there are 8 muscles which comprises of the modulus. The modulus comprises of 8 muscles. You have the orbicularis oris, levator anguli oris, zygomaticus major, buccinator, rhizorius, depressor anguli oris, and all of this comprises of the modulus. Okay. So again, the 8 muscles are the buccinator, rhizorius, the zygomaticus major, platysma, levator anguli oris, depressor anguli oris, depressor labii inferioris, and the orbicularis oris, the 8 muscles which comprises of the modulus. So zygomaticus major, it is a part of the modulus, but the zygomaticus minor is not. Next was a picture question. So this was a picture which was given, and the question was, what technique of implant is shown here? Which technique of implanting is shown here? What is this technique called as? So it is, the options were, is it a socket shield technique? Is it an immediate implant technique? Is it a subperiosteal implant technique or a GBR technique? The answer is a socket shield technique. See, socket shield technique is also called as a PET technique, that is partial extraction technique. All right. So it is called as socket shield technique or a partial extraction technique. In this technique, the first thing that you do is you do a tooth decoronation. That is, the crown portion is removed. Okay. And the tooth is trimmed to the height of your bone, till the level of your bone. Then you split the tooth. All right. You make a cut in the center of the tooth and retain the buccal part of the root there and remove the palatal part. All right. So this is called as your buccal shield. Whereas this procedure is mainly done in cases where you have a very thin buccal cortical plate. Okay. And also in cases where you have a very thin type of gingival gingiva. Okay. So after the buccal shield is created, the height is adjusted to the level of the bone. And then what you do is prepare a implant socket, which is palatal to this buccal shield. Do not touch the buccal shield. You take it a bit palatal, extend it beyond your root socket, and then you place the implant. Okay. After doing that, the what it is called as your jumping distance. Okay, the space between your socket walls and your implant is called as a jumping distance. This jumping distance is basically grafted and the prosthetic phase is started. So that is called as socket shield technique, or it is also called as partial extraction technique, PET. Okay. Are we clear till now? Are we clear till now, guys? Next question is, what is the distance from the center of the incisive papilla to the central incisor? From the center of the incisive papilla to the central incisor. Please note, your incisive papilla, you can divide it into 3 portions. Okay. And the question is the center of the incisive papilla. That's why I said the center of the incisive papilla. When you talk about the center of the incisive papilla, the distance is 8 to 10 millimeters. Okay. If it was the top of the incisive papilla, it is 6 to 8 millimeters. Or if it is below that, it is almost about 10 to 12 millimeters. Okay. So from the center of the incisive papilla to the central incisors, it is going to be 8 to 10 millimeters. All right. When we talk about, the muscles, which is used for border molding and for neutral zone mechanism. Okay, what is the neutral zone basically? Neutral zone is the area between your lips and your tongue where the tooth is placed, which has maximum stability. That is, the muscular forces from the tongue and the lips are in equilibrium with each other. So the denture will not dislodge. Rather, it will be more stable when placed in that neutral zone. Okay. So the muscles there in this area will form a cartwheel like, sorry, will form a cartwheel like musculature. Okay. Now, which of these muscles, which 3 muscles will form this cartwheel like musculature for your border molding and neutral zone? Is a question. Is it levator anguli oris, orbicularis oris, and triangularis? Buccinator masseter superior constrictor, buccinator masseter levator anguli oris, triangularis risorius, and levator anguli oris. The answer is going to be buccinator, masseter, and levator anguli oris. Okay. Coming to the next question, which was asked, a complete edentulous mandible for the dentist decides to give an overdenture with mini implants. In which case is it given? Which case is this given? Anybody? It is given to achieve a definitive prosthesis in completely healed of socket of less width and height, to achieve temporary prosthesis in completely healed socket, to achieve definitive prosthesis in recently extracted socket with sufficient height and width, to achieve temporary prosthesis in recently extracted socket. Which of these? It is given in to have a definitive prosthesis in a completely healed socket with less width and height. Now, if you have an ideal width and height for the implant, you don't have to go for a mini implant. Rather, you can go for a normal implant, right? Only in cases where you do not have the provision for the regular width and height available, do you go for a mini implant. All right. So the option which has sufficient width and height is ruled out there. Next is it to give a temporary prosthesis or a definitive prosthesis? You can surely give a definitive prosthesis on a mini implant. Okay, when you give a 2 or 4 mini implants, you can give a definitive prosthesis. You are not planning to, remove these implants and then redo the prosthesis, because on a mini implant you can only give a normal overdenture. You are not planning to give a fixed denture, right? So it is to give a definitive prosthesis for completely healed socket of less width and height. Why in a completely healed socket? Because a mini implant does not rely completely on osseointegration. Okay, initial stability, and then later on slight amount of osseointegration, it is what you're looking for. All right. So because the height and the width is very less, you're not going to place it into a socket, extracted socket, and put it with graft. Then you are not able to give the prosthesis on top of that. It will never stay. It will dislodge. So in that case, you always prefer to give a mini implant for a healed socket. Coming to the masseteric notch, I think there were quite lot of questions which were associated with the masseteric notch. Okay. Now, what is the masseteric notch? The action of which muscle on which muscle causes the masseteric notch? The masseteric notch is formed by the action of the masseter on the buccinator. Okay, especially when you're talking about the distobuccal sulcus of the lower, there is where the action of the masseter on the buccinator is what causes your masseteric notch. A clinical scenario is given in which an edentulous patient, after receiving a denture, found it very tight initially. Okay, so the patient is very happy with the denture because it is quite tight. But after some time, the denture gets loose. For example, he wears the denture in the morning. The denture is extremely tight fitting. After some time, the denture starts getting loose. What could be the cause of such an error? Is it the basal seat error? Is it an occlusal error, an impression error, or an increase in the vertical dimension? What could be the reason of the error? What could be the cause of the error? Anyone? It is because of the occlusal error, not increased vertical dimension. It is because of the occlusal error. Okay. That is why they say when you have a vertical dimension increase, usually the first thing to happen is you have pain. You have pain in the denture bearing area. That is the complete ridge where your denture bearing area is. There you will have pain because of the increase in vertical dimension. Second, you will have clicking of the denture. When the patient is trying to talk, the denture is going to hit each other, which is going to have a clicking sound. So that is the initial complaint. Only after that will the looseness be shown. But when you have an occlusal error, the denture base is extremely good, the impression was correct, everything else is fine. The denture fits, is retentive, and it fits properly. But through the day, after using it for a couple of hours, what happens is when the patient tries to chew or eat something, is when occlusion comes into play. Due to the occlusal error, the denture starts becoming loose. All right. So that is how it shows as a occlusal error. Loss of vertical dimension in a completely edentulous patient causes what changes in the mandible? What happens when your patient becomes completely edentulous and there's a lot of loss of the vertical dimension? you have something called as a pseudo prognatism which happens. That is the first thing that happens. So what happens is there is a forward movement of the mandible. If you see most of the elderly patients who have lost their teeth and who are edentulous for a period of time, most of them look like they have a class 3. Or if they're placing a denture after a very long period of time, they will not be able to bite in the proper centric. You'll have to guide them into centric. They always have a tendency to bring the denture in front and bite. Why? Because the structure of the maxilla and mandible are so designed that only if the patient, that is when the patient is edentulous, only if the patient tries to bring the mandible in front and tries to touch it anteriorly, there is no chance that the posterior will contact in an edentulous patient. So the patient, just to get that feeling of proprioception or feeling of being eating or chewing, the patient tries to bring the mandible in front and to hit the lower anterior to the upper anterior portion. Okay, so that is why you feel that the mandible is moving forward. The mandible is not growing forward, rather they're trying to bring it forward for that contact. Next is another clinical scenario which was asked. A 54-year-old patient who's provided with a positive history of myocardial infarction 3 months ago wants to replace his missing teeth with dentures. Okay. On examination, it was noticed that the patient has only two teeth which are very periodontally compromised. What is the current treatment plan for the patient? If the patient had completely missing teeth and no teeth at all, then it was okay to immediately proceed with the denture fabrication. But in this case, since he has two periodontally weak teeth, that has to undergo extraction. Now, mostly what happens with myocardial infarction is that they are put on, antiplatelet and anticoagulant therapy. So aspirin, clopidogrel, all these tablets are they have put through. And in a history of 3 months, they will never allow for stopping any of these medications to proceed with extraction. Okay. So in such a case, it is ideal to wait for 6 months and then go for an extraction. So since already 3 months has passed, you wait for another 3 more months and then go for an interim prosthesis. Okay. Why an interim prosthesis is because the patient is already dentureless for a very long period of time. So you're going to extract and give the denture immediately. You're not going to ask the patient wait 2-3 months and then we'll give the denture. So you give a interim prosthesis and then maybe later on reline it or do a newer denture depending on the patient availability or the need for the patient. What is the choice of impression material for a flabby ridge? Anybody? Irreversible hydrocolloid, agar, or I mean, like alginate, you have agar, addition silicon, or impression compound. Anybody? The first thing about a flabby ridge is that you are always going to look for an impression material which is mucostatic, not an impression material which is mucocompressive. So in this, your impression compound and your irreversible hydrocolloid, both of them being mucocompressive, including agar, is mucocompressive to a certain limit. Okay, so those three options will be ruled out. If there was an option of impression plaster, that would be your first choice of answer. If there was impression plaster, that will definitely be the initial choice of answer. But since it is not there, if impression plaster is not available, you can always use light body of an addition silicon for the impression of a flabby ridge. Okay, so you can always use light body of an addition silicon for your flabby ridge impression material. Clear, guys? Always go for a mucostatic impression material. Very similar to the question asked earlier about the masseteric notch, the distobuccal flange of the mandible is shaped by the masseteric notch is that area in the distobuccal area, which is shaped by the action of the masseter on the buccinator. Okay. So what happens here, the kind of mechanism, what happens here is simple. When the masseter is activated, it pushes inward against the buccinator and produces a bulge into the mouth. When properly molded, the distobuccal border of the impression must converge superiorly and medially, forming a groove, which is called as your masseteric groove. Okay, that is what happens. That is how the masseteric notch is found in the impression. What is a term for the triangular gap which is observed between the upper and lower dental arches during the forward movement of the lower jaw? What is the term of the triangular gap? No one. That's a very simple question, isn't it? When you bring your mandible in front, that is when you bring it into edge to edge relationship, your upper teeth and your lower teeth in edge to edge relationship, there is a triangular gap which is formed between the posterior teeth. That is behind your canine. There is a triangular gap between all the posterior teeth. This phenomenon is called as Christensen's phenomenon. Okay. It cannot be balanced occlusion. Why? Because the definition of balanced occlusion, simple as that. Okay. It is the bilateral simultaneous contact of the anterior and posterior maxillary and mandibular teeth in occlusion. So in centric and also eccentric relation, right? So in a balanced occlusion, when you bring your balanced denture in the front or in protrusion, any centric or eccentric position, there is bilateral simultaneous contact, that is either side, and same time there is a contact between anterior and posterior teeth, even if it is on a single point, but there is a contact. That is the concept of balanced occlusion. And in Christensen's phenomenon, we don't want that. You have contact only the anterior and the posteriors will disocclude, right? So it is called as Christensen's phenomenon. What is the function of a crest module in an implant? Basically, what is the crest module? So you have an implant body. So the answer is it is the connection between the implant and the abutment, or the prosthetic part and the surgical part. Okay. So basically, it is the transosteal region of the implant body, which is designed to accept the prosthetic component in one piece or a two-piece implant system. So in this picture, when you can see, this is the body of the implant. Towards the end is the apex. And on top of it, you have something called as a crest module or a collar. Okay. Now the shape and the size of the crest module will largely, influence the failure of the prosthetic phase. Okay. Gingival healing, no. Gingival healing is not promoted because once the crest module, it goes into the bone. So the gingival is definitely going to grow over it unless and until you're going to put a healing abutment or a gingival former. So the gingival healing is basically contoured by the gingival former or your healing abutment, as it is called. Promotes osseointegration, not much, because the maximum bone loss that an implant is shown to have after a year or two is always around the crest module. Okay. The osseointegration mostly forms on the body where the threads are present. What is a Nesbit prosthesis? What is a Nesbit prosthesis? Anybody? Is it a ear prosthesis, orbital prosthesis, unilateral partial denture, or a guide plane in hemimandibulectomy? Which is it? It is a unilateral partial denture. Okay. It is a normal a RPD without a whole plate. It's like this. Okay. An RPD which has two clasps on either side that is guarded. It's like probably in a class 3 situation. It has, or yeah. So it is a unilateral, and it is does not have a complete plate. Okay. It is a small piece which has only the tooth and two clasps which is attaching to the adjacent tooth. This is called as a Nesbit prosthesis. The question from RPD. Okay. So which major connector is rigid but not bulky, but still provides good support? Among these, okay, which is not, which is rigid, which is not bulky and has good support? First, you have single palatal bar, you have horseshoe shaped major connector, anteroposterior strap or bar, and a complete palate. The answer will be an anteroposterior strap or bar. It is rigid, not bulky compared to the others, because all the others have, more coverage. Palatal bar is thicker. Okay, palatal bar is thicker than your anteroposterior bar. Okay, and then complete palate and horseshoe shape, both of them are more widespread in the area. So this is how basically your anteroposterior strap and bar will look like. In a patient with periodontally compromised anteriors, the choice of major connector is, remember, your periodontally compromised anteriors. Which will you choose as your major connector? Is it a label bar, sublingual bar, lingual bar, or a lingual plate? When you have to give a lingual bar, you have to have a proper depth, gingival depth in the sulcus depth of more than about 8 millimeters in the anterior region. Now, irrespective of that, the depth is not mentioned, but rather only the periodontal condition of the anterior is given. So among these, only lingual plate has the ability to splint your anterior tooth, right? So that is why the option will be for lingual plate. So this is how your lingual plate will help with splinting of your periodontally compromised anteriors. It will support on the palatal lingual aspect of the tooth. A hydroxyapatite coated implant preferred in comparison to the titanium machine implant in extraction site of the upper left second molar, which all cases except need for greater BIC, type 1 bone, freshly extracted site, and newly grafted site. Let's go option by option. Okay. When you go in a newly grafted site and a freshly extracted site, you can always use a hydroxy-coated implant. Okay. The question here is, when you can choose between hydroxy-coated implant and titanium machine implant, most of the places you can always give hydroxy-coated implant except, okay, that is a question. So that except has to be type 1 bone. Why? Because in all the other three, there are better chances for osseointegration with hydroxy-coated implants. Okay, you have a better advantage, in a hydroxyapatite coated implant, you definitely have better bone implant ratio, this ratio. And then you have in a freshly extracted site and a newly grafted site also, you have a more advantage for a hydroxyapatite implant. Whereas in a type 1 bone is a hard cortical bone. In such a case, what happens in most of the cases is that they require not osseointegration, rather osseo fixation is more important, which cannot be given by hydroxyapatite implant. So type 1 bone, if you have a type 1 bone, you prefer to give a titanium implant. Quite a tricky question which was there this time. The options were not very clear. You have to choose one from the best. Okay. A 39-year-old patient with endodontically treated upper first molar. Crown height was less, so finish line is placed subgingivally. What is the advantage of doing so? Place it on hard enamel, difficulty in assessing the restoration and recall visit, to place it in an aesthetic zone. Since it is the posterior first molar, aesthetics doesn't come into play. Now, assessing the restoration in a recall visit, no. But rather, when you're going more subgingivally in this case, there is a chance you are able to place the margin on better hard enamel. Okay. So that is why option A will be the answer compared to the other answers. What is the advantage of giving a subgingival finish line? What is the major advantage of giving a subgingival finish line? Easier to record impression? No. Accurate fit of prosthesis? Maybe, you never know, because once it is subgingival, when you're keeping the prosthesis, or the maximum you can do is check it with an RVG. You cannot check it clinically. Maintenance of good oral health completely depends on the patient. If maintenance is poor, you have chances of food lodgement, enlargement of the gums, and so on and so forth, because you are going to encroach slightly into the biological width. So the answer is going to be superior aesthetics. The advantage of a subgingival finish line is superior in aesthetics, because there is no chance there is a marginal exposure or the finish line exposure. That is not going to be seen. So you have superior aesthetics. Coming to this picture question again, a pyre abutment was given for a patient for this condition. Okay, so you have 2-1, 2-2, 2-3, 2-4 is missing, 2-6 is missing. You have 2-5 and 2-7. All right. Now they have told you this is a pyre abutment case. They've given the answer also. You're going to give a key and keyway. All right. Now, only thing you need to decide is where do you give the key and where do you give the keyway. Key is present on the distal surface of the pyre abutment and keyway on the mesial surface of the distal abutment. Key is present on the mesial surface of the distal abutment and the keyway on the distal surface of the pyre abutment. Key is on the mesial surface of the pyre abutment and keyway on the distal surface of the medial abutment. Key is present on the distal surface of the mesial abutment and keyway on the mesial surface of the pyre abutment. The first part of your prosthesis when you give a key and keyway, that is the mesial segment. If you, let's say you're dividing this into a mesial segment and a distal segment. Your mesial segment will be of FPD, which is coming from 2-3, 2-4, 2-5. Okay. Next portion is your next part of the FPD, which has 2-6 and 2-7. So mostly what you do is you have a keyway on the pyre abutment on the distal aspect of the pyre abutment. The keyway or the slot will be on the distal aspect of the pyre abutment. Now the 2-6 and 2-7, that has a key, that is the mesial of the 2-6 will have a key, and that will go and lock into the keyway. All right. So the key is present on the mesial surface of the distal abutment and the keyway in the distal surface of the pyre abutment. Clear? This is how it will usually come as. So basically, in a case of a pyre abutment, you are planning to give a non-rigid connector, right? A key and keyway connection. What is the advantage of a screw-retained prosthesis? Increase adhesion between abutment and prosthesis. There is no point of, there is no concept of adhesion when you are talking about a screw-retained prosthesis, right? The whole strength is held by the screw. So there is no concept of adhesion there. Accurate fit of the prosthesis. It can be. I'm not, it is, I don't deny that fact. It can be. But is that the major advantage? No. Ease of fabrication. Actually not. A screw retained prosthesis is much more difficult to fabricate than a cement retained prosthesis from the lab aspect. Can we accommodate in decreased interclusal space? Now that will be the answer. Why? Because that is solely for screw retained prosthesis. Even a cement retained prosthesis can give you an accurate fit of the prosthesis, right? But your screw retained prosthesis is used for cases which has less than about maybe let's say 5 to 6 millimeters of interclusal space. In such a case, you can always give a screw retained prosthesis. If you have an increased interclusal space, you can't give a screw retained prosthesis. Why? Because the crown height will be so huge and the wrench or the driver will never go in through till you reach the screw to torque it up. One. Second thing is you are going to give a vertical cantilever on top of it. You have something called as a horizontal cantilever and a vertical cantilever. So if you have a too long a prosthesis, it is going to cause a vertical cantilever also. Okay, doctor? You're unable to see me or you're unable to see the PPT? Okay now? Okay. All right. So in such a case, so the answer is definitely going to be, it is used in cases with reduced interocclusal space. Now, this is pertaining to, when you are talking about a single prosthesis or a small FPD or something like that. I am not talking about a full mouth rehabilitation. Now, when it comes to a full mouth rehabilitation case, the whole ideas will change. Okay. But even there, screw retained prosthesis is most ideal. But in such a situation, you are not planning to give a, again, you will not, you will be, having to choose between, you cannot do it in a case of decreased intraocclusal space. Next is from maxillofacial prosthesis. Okay. Bilateral anteroposterior resection classified by Aramini is which class? Class 1, class 2, class 3, or class 4? It is class 4, not class 2. This is basically Aramini's classification. Okay. So in class 1, you have a midline resection. Class 2, you have a unilateral resection. Class 3, you have central resection. Class 4, you have bilateral anteroposterior resection. In class 4, if you see, it is crossing the midline. Okay, so it becomes bilateral. Some portion of the anterior and one side posterior. So anteroposterior resection. So it is class 4. Okay. Class 5 is posterior resection and class 6 is the anterior resection. So this is basically Aramini's classification.
Ma'am,
what is the purpose of an implant analog? When you're talking about the components of an implant, what is the purpose or the function of an implant analog? What does an implant analog do? Replicates the implant in the cast for transfer coping, impression making of implant, or for surgical placement. Your transfer coping or your impression coping is used for making the impression. And for surgical placement, you use something called as a surgical stent. All right. So the implant body is inserted into the implant into the patient's mouth. Initially, you cover it with a cover screw. After you open it for your second stage implant surgery, remove the cover screw and put something called as a gingival former or your healing abutment. Okay. After the gums have healed well, You remove the implant, the gingival former, and you place your transfer coping or impression coping. Depending on the case, you choose a closed tray or an open tray. You place the transfer coping in the implant, connected to the implant, make the impression, take out the transfer coping, place it in the impression, attach your implant analog to it. So that now what happens is your implant impression coping and your implant analog together will show you the position of the implant. You send it to the lab, they will apply Vaseline on the impression coping and the analog and pour a cast. So your implant analog goes inside the cast and your impression coping will stand out and it is removed out. Okay, so it replicates the implant in the cast. So on that implant analog is where you will be fabricating your, attaching your abutment and fabricating the crown. So basically, this is how an implant analog will look like. It doesn't have full threads like an implant, but if you see, initial top portion will be smooth and the lower portion will have maybe 2 or 3 slots so that it holds on to the cast. So this is how it looks like. And you see in this first one, this is your screwdriver or your torque screw. This is your impression coping. This is your implant analog. Now, your implant analog is attached to your impression coping, and this is how it will form as a single unit. So this is how it will be. It is placed back into your impression, and the cast is poured. Now, this pink color that you see here, it is called as your gingival replicator. Okay, that's what it is called as. That is, it is soft. It replicates your gingiva or your gum shade. Okay, the position of your gum. It is it's called as a gum mask. That's all. That is also. It is also called like that. Gum mask also can be called. Okay. So once you take out your impression coping, this, if you see the last picture G, this is how your impression implant analog will look like in the cast. So now you know correctly where the implant is placed and where is the position of your implant. What is the most common cause of failure of implant retained prosthesis? Screw loosening, implant mobility, peri-implantitis, or a prosthetic failure? Most common cause of implant retained prosthesis. Since they have not mentioned if it is a cement retain or a screw retain, screw loosening, you cannot choose here. Next is implant mobility. Now, implant mobility is an aftermath of peri-implantitis. Okay. Prosthetic failure. Prosthetic failure, the most common thing that happens is a screw loosening or an occlusal error. But the initial, even that will show initial signs of peri-implantitis. So most common failure reason would be peri-implantitis. Okay. Even from a small infection, a periapical infection or a periodontal infection of the adjacent teeth, anything can cause a peri-implantitis to the implant. Hence, proper cleaning and maintenance is very important. What is this kind of a prosthesis called as? Your resin bonded bridge, right? Like a Maryland or a Virginia bridge, anything. Okay. So it is a resin bonded bridge. And what is a contraindication of a resin bonded bridge? Short span bridge. You have a single posterior tooth restoration, periodontal splinting, or a deep bite. In which cases is it contraindicated? Any case which does not have an ideal horizontal overlap. That is, if you have a deep bite, it is contraindicated. You cannot give a resin bonded prosthesis in a case of a deep bite. Short span bridge, yes, you can give a resin bonded. Periodontal splinting, it does help to periodontally splint the adjacent weak tooth. Single posterior tooth restoration can be done. Even single tooth posterior can be done as a resin bonded bridge. So the answer is a deep bite. A patient
Ma'am,
has undergone an extraction of the maxillary central incisor
ma'am,
and wants to replace the missing tooth. Which type of Pontic is ideal to give in this case? A recent extraction is undergone. Yes, Astha.
ma'am, can you hear me? Hello? Mom.
Okay, till Astha types, I think we'll go with this question. Okay. Okay, just keep the question in mind. We'll come back to it after we finish the presentation. I don't think there's much more. We'll come back to this question, okay? The resin bonded, right? We'll come back to that. Oh, there was a change in the question. Okay, then just send me the question, okay? This is the question that I got. Just put up the question which you had got, okay? All right. In this case, you will prefer to go for an ovate pontic. Why? Because first you are talking of an immediate extraction place case. In this case, if you give a ridge lap, what will happen in the, later on stage is that once there is shrinkage of the ridge, or there is, after complete healing, there will be a lot of gap which is present. So that will create an issue. So you always prefer to give an ovate type of Pontic in an immediate extraction patient, especially in the maxillary central incisor. In the case of a unilateral distal extension partial denture, where will you place the indirect retainer? Close to the fulcrum, away from the fulcrum, center of the tooth, or on the canine? Okay, now let's say you have a case away from the fulcrum. Why do you want to place it away from the fulcrum? You always place it. But in this case, see, when you are talking about a unilateral distal extension case, in the case of a unilateral distal extension case, mostly it is placed on the canine. Okay, that is where mostly the fulcrum dissection will come. Wherever your distal extension starts, be it your lateral, be it your lateral, or be it your canine, or be it your premolar. And let's say if you're talking about the lower arch, you have all the tooth in the fourth quadrant, you have till the canine in the third quadrant. When you have a fulcrum line which crosses from your 7 to your 3, till your premolar, let's say till your 4, still when you keep it, it's always on the canine on the opposite side, no? So it is mostly on the canine. For a unilateral distal extension, mostly it is on the canine. Okay, your indirect retainer. Your answer of it is, if it your answer that it is away from the fulcrum is not wrong. But the thing is, when you have the answer of on the canine, because most commonly this away from the fulcrum is going to come on the canine. Okay, unless and until maybe you have it only on your, maybe you have the fulcrum line, let's say from your 6 to 6. In such a case, is the only place where you might necessarily not go and place it on the canine. But mostly when you talk about a unilateral distal extension, you have it on the canine. Okay, that's okay. Antis law is related to, what is Antis law related to? Pericemental area of the replaced and missing teeth, selection of abutment, selection of prosthetic tooth material, or placement of indirect retainer. Difference of thoughts between Dr. Astha and Dr. Aishwarya. Is it? Actually, both of the answers are correct. Auntie's law is basically related. Are you talking something? Oh, I'm so sorry. I can't hear you guys.
Ma'am.
Can you just type? I'm not able to hear. I think you guys are muted. I thought
No,
yeah,
ma'am.
all of you are muted. Or is it that just I can't hear?
Um,
So now in this question, no, again, Auntie's law basically is related to the pericemental area of replaced and missing teeth. That is the definition of Auntie's law. Now, where is it used? It is used in the selection of abutment. So you can't say either of you guys are wrong, but more ideally would be the pericemental area of the replaced and the missing teeth. Uh, so
ma'am. Ma'am.
pericemental area of the replaced and missing teeth. Okay, just a second.
Ma'am.
Okay, can you try unmuting? Not allowing. I'm so sorry because the I think the admins have lost not allowed to mute. I mean to unmute, and I'm not the admin. Okay. Actually, this can again slightly they can show a small confusion because pericemental area of the missing and the abutment teeth is what Auntie's law is about, right? So it is not the replaced and the missing teeth because replaced teeth and the missing teeth are the same. So it has to be B, selection of the abutment. Aishwarya Astha is correct. Okay, so this one, please note, it is B. Okay, it is selection of the abutment. Now, in this case, a female patient has missing left lateral incisor, canine, and the first premolar. So ideally, she doesn't have, let's say if it's the upper arch, she doesn't have 2-2, 2-3, and 2-4. All right. The most appropriate treatment in this case, cantilever on second premolar, no. Cantilever on the right lateral incisor. Why would you cantilever from the right lateral incisor? The centrals are there, right? So that's not the answer. And FPD, okay, FPD connecting where to where? From the central incisor till the first molar, very long span. And replacing a canine is not possible because a very, very long span with a canine, it'll not stay. So definitely the answer is going to be an RPD. Yes. D is going to be the option. So you have to give an RPD in such a case. Okay. That's it. Okay. So these were the questions which were asked now. Okay, let's come back to Dr. Astha. Astha, can you please put up the question of the कौन सा था वो resin bonded bridge का? What was the question? If you remember, or if you remember the question, can you put it in the group so we can discuss on that there? Please put it up in the group, no, in WhatsApp. I think that will be easier. Okay, so you are saying they were asking for the indication. Okay, Fine. If it is a contraindication they were asking for, you're clearly not going to give it in a case with a uh, deep bite. Yeah, if you see most of the questions, even now, most of the questions, the question is twisted, but they're all basically they're all questions which are asked, right? So the way they ask the question is the only thing that confuses. Answer is always straightforward. That's why we say you need to take a little bit of time to actually read the question and understand the question and then go for the answer. Answering will not take time. Reading and understanding the question will take more time, right? All right. So that's it. Okay. Nice. Just an hour and we have finished. That's also this year. These were the questions which were asked from Prostho. Not more questions like that, but I guess you did have more questions from implants this time, though. Okay. Were you able to answer the socket shield question? This one? Did you answer this question? Okay. This one, I guess Dr. Aishwarya did get it wrong. She put her 6 to 8 millimeters. Huh? It's 8 to 10 millimeters. See, distance from the incisive papilla to the central incisors. There are 3 areas. That is why they have mentioned the center of the incisive papilla. It is, if it is from the top, it is 6 to 8 millimeters, then 8 to 10, and then it is 10 to 12 millimeters. Okay. But yes, this time again, I did see a lot of questions from the musculature, from your modulus and the masseteric notch, distobuccal muscles, muscles of the border molding and neutral zone. Those questions were quite seen. And yeah, CD questions and all, most of them are the regular questions, I guess. Christensen's phenomenon, very easy question, very common question. We did discuss that last time too. And parts of the implants, okay. This was a little bit tricky. Were you able to answer this? Yes, great. If you see in cast partials, they always stick to the major connectors and the indirect retainers, or mostly they will ask you from the direct retainers. Now, so that is what is the most common questions they have asked. Um, most questions of pyre abutment again is a very important topic which we have discussed, studied. Rest everything, just one, hardly a question from myofunctional. But yes, this time I think implant they have given a slight, quite a lot of this. Okay, so that's it. So let's end it up here. All right.